So we are live now. With all your permission,
Okay.
I'm starting this session.
Yeah. Faraz, you're mute.
Yes, sir. I'm just starting, sir. I'm just. Good evening, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, Dr. Quresh B. Maskati, sir. Sir has done MBBS, MS, DOMS, FCPS, FICS, and consultant ophthalmologist at Maskati Eye Clinic, Mumbai. Today, sir is going to discuss on a topic glaucoma, diagnosis and management. Let me tell you overview of the topic. Glaucoma is a group of eye disorder characterized by progressive deterioration of the ectopic nerves that can lead to vision loss. The risk factor of glaucoma include age, family history of glaucoma, type 2 diabetes mellitus, hypotension, hypothyroidism, obstructive sleep apnea, cardiovascular disease, and myopia. To discuss more about this topic, I would like to invite Dr. Quresh Maskati, sir. Sir, over to you. Kindly proceed with from here.
Thank you so much. And good evening, all of you. This is a very interesting topic that we have selected, that is glaucoma. You know, in many conditions, you can see the disease in the eye. For example, if there is a cataract, you see a white shadow inside the eye. Patient sees less, so he knows that there is a cataract and he knows he has to rush to the doctor. The problem in glaucoma is that till the end, the patient is seeing well. Only thing is seeing as if through a tube, like that. Just a little field of vision in the center is preserved. So he thinks that all is well. They don't come to the doctor in time. The pressure keeps on rising. They don't know. More than 50% of them don't have headaches or any symptoms. That's why glaucoma is called a silent thief of sight. I'll just share my screen with you. So this is I written glaucoma for the family physician, but it is equally, it will be equally useful to patients, to the general public, and to eye surgeons as well. We'll try and cover it in all grades. So let us first, for those of us who are not familiar with what the eye looks like, there is a factory inside the eye which produces the fluid in the eye which retains the shape of the eye. The fluid in the eye is called the aqueous humor. So you can see that there is an aqueous humor factory which is just behind the cornea, where the transparent glass in front of the watch, that's called the cornea. Just behind that is the iris, the brown portion of the eye, and attached to the iris is a structure called the ciliary body. Actually, it's this iris is attached to the ciliary body. Now, ciliary body is the factory in which the aqueous humor is made. So God has designed so that the aqueous humor is made just in enough quantity. It is required to bathe the cornea. So the front portion that you can see.
Sir. Your slides are not visible, sir. You have not shared the screens. Can you please?
Oh, I'm sorry.
Yeah, no problems. And
just one moment.
fine, sir. It's visible now, sir. Make it full screen on. Fine, sir. Perfect. Continue, sir. Thank
So
you.
this is the, I was telling you that the front portion is the cornea, and behind that is the ciliary body. Ciliary body is the factory which produces the aqueous humor or the fluid of the eye. It goes from behind the iris, which is the brown portion, and comes into the front of the lens. That area is known as the anterior cavity or anterior chamber. It is required because it carries nutrients to bathe and to give nutrition to the cornea, which is in front. If there is too much of production, it's like a tap in the basin being turned on too fast, then the basin tends to get choked up because the drainage is not able to take care of it. Similarly, if there is too much production of aqueous, you get glaucoma or raised pressure inside the eye. There are tiny openings just near the iris through which the aqueous flows out. I have written it as aqueous humor exit through a canal called the Schlem's canal, and there is a meshwork called the trabecular meshwork through which it flows out. So if that area is choked up, then the fluid doesn't go out fast enough, and again you'll get undue pressure in the eye, which ultimately presses on the optic nerve, which you can see at the back of the eye, and that causes damage and permanent loss of vision. So glaucoma is defined as a chronic because it's over a period of time, multifactorial. As Faraz told you just now, it has many factors: thyroid, hypertension, diabetes, myopia. Many factors contribute. Even if you don't sleep well, sleep apnea, you can get this. So multifactorial, it's a progressive disease because, as I told you, either the tap is open too much or the drainage from that basin of ours is choked. So it will progress, and the nerve of the eye, which is normally very pink, it becomes whiter and whiter, as you can see here. That means the blood supply is getting hampered to the nerve. And so that is why we say it is irreversible damage to the optic nerve. And whatever damage has occurred, you cannot reverse with medicine, with surgery, with laser, with anything. That's why we call it a silent thief of sight. It is the second most common cause of blindness in USA and European countries. We don't have such statistics with us. And even in the developed countries, in the world's richest countries, 50% of the patients in these countries remain undiagnosed. That means 50% of people who have glaucoma don't know they have glaucoma. In our country, I would say 80% of those who have glaucoma don't know they have glaucoma till it is too late. Why? Because glaucoma patients are asymptomatic. By that, they have no symptoms. They have no headache. They have no loss of vision. They have no redness in the eye, no pricking sensation. So they don't know, and they don't come to a doctor. In India, typically, there is no such thing as a preventive checkup, which is advised. Everybody above the age of 40 should go annually to an eye surgeon for checkup, not to their optician, because only eye surgeon checks the pressure, looks inside the eye, and looks at the nerve, etc. So why do I say too late? You see the picture there of normal vision with those wonderful coconut trees and the palm and the beach. A glaucoma person in his end stages will see as if he's looking through a tube. So everything around is black. He sees only a little bit of the trunk of the tree and a couple of leaves. That's it. So that vision shrinks from the side. So how do we diagnose glaucoma? Basically, we have three things we look at. The eye surgeon will look at the optic nerve to see what are the changes on the optic nerve head. Head is the part of the nerve which you can see through the eye. Then we will do a test called a visual field test. I told you that the visual field shrinks as if you're looking through a tube. So if you see that picture next to visual field defects, the whitish gray area is still seeing vision, but the black area around is all the vision which is already gone. So this is tubular vision. So we have machines by which we can do visual field analysis, VFA. And we look at the eye pressure to see whether the eye pressure is normal or it is raised. The funny thing about glaucoma is that you can have raised the damage to the eye even with a normal pressure, because just as somebody may have 150 by 100 blood pressure and cause no damage to the heart, somebody else may have 130 by 90 blood pressure and his heart is damaged. So everybody's capacity to tolerate a pressure is different. Some people, the normal pressure is up to about 21. Some people can't tolerate even 18 or 19 pressure, and they start showing changes in the nerve or in the visual field. So I was telling you about normal tension or low tension glaucoma. About 50% of patients, even their eye pressure is normal. So even if they go, some opticians abroad, not in India, even check eye pressures. But if they check eye pressure, they would still find it normal. The pressure is too high if the nerve is already affected. So for such patients, even if the pressure is 21, I will bring the pressure down to 14 or 15. That decision only the eye surgeon can take. Why will I do that? Because the single biggest risk factor for pressure for glaucoma progression is raised intraocular pressure or IOP. So lowering the IOP, intraocular pressure, reduces the risk of glaucoma progression. How do we measure the IOP or the intraocular pressure? In the old days, we used to make the patient lie down, put some local anesthesia drops in the eye, and use an instrument called the Schematic tonometer, as you can see there. When you press it on the patient's cornea, then there was a indicator like an arrow which moved and pointed to a particular number, and then we had a chart to convert that number into the pressure. So that was called the Schematic tonometer. That's the first picture. It has largely been replaced except in some government medical colleges. No one uses that anymore. We have better devices like the TonoPen, the rebound tonometer. Then we have rebound tonometer even for home use, just like you have a blood glucose home kit by which you can check your own glucose levels, or your blood pressure instrument by which you can check your own BP at home. Similarly, we have now instruments like a rebound tonometer for home use by which you can check your own pressure at home. And this is a Perkins handheld tonometer. There are many different ways of accurately measuring the pressure on the eye. The gold standard is what is called Goldman applanation tonometry, or GAT, which is done only by the eye surgeon on a slit lamp microscope. So Goldman applanation tonometry, or GAT, the machine is attached to a slit lamp, is the gold standard. We put a drop of dye in the eye called fluorescein, and there is this conical device that touches the cornea and presses on the cornea. So the pressure on the cornea is resisted by the pressure inside the eye. So the more pressure I need with that cone, plastic cone, to press to make that cornea flat, higher is the patient's pressure. That is the principle. So how do we know that it is correct? It is aligned. If you see two semicircles, one above the other, and both are perfectly aligned, that is the endpoint, and then you can read the pressure. So this is Goldman applanation tonometry. So all glaucoma patients, once they're diagnosed, usually the follow-up is done on GAT or Goldman applanation tonometry. Then I told you that, so one is the eye pressure. Second is that looking at the optic nerve. So we have instruments called ophthalmoscopes by which we can quickly look into the eye, inside the eye. The eye is the only part of the body where you can look right inside. Even skin, you can't look under the skin. But here you can look right in and look at the retina and look at the optic nerve. The process is called ophthalmoscopy. And there are two ophthalmoscopes, a direct ophthalmoscope by which you go close to the patient and hold that like a pen instrument, which that lady is holding in the center. And the other one is an indirect ophthalmoscope where we have a lens which comes between my mirrors and the eye, and I'm standing about 16 to 18 inches away from the patient. So from far away, I can look. And what do I see when I look inside? The normal picture that you can see, where the optic nerve is pink. You can see how pink it is, that central disc, which is pink, and blood vessels are coming out from that. This is a normal eye. This is what we see. In glaucoma, the center of it starts becoming pale. That's called the optic disc. The center of the optic nerve is the optic disc. And that the nerves get, there are about 2 million nerves going through that optic nerve. It's like multiple fibers going in your TV cable going to the rooftop. So every retinal cell, 2 million retinal cells, sends one fiber through that optic nerve to the brain. So the peripheral nerve fibers keep dying because of raised pressure. And you can see this, whiteness in that glaucoma. So the optic disc becomes bigger, and that is called, the process is called cupping. If you see the picture above the ophthalmoscopes, that we measure something called cup disc ratio. Cup is the central white portion, and the rest of the optic nerve, which is pink, that's called the disc. So the cup disc ratio in the first picture is 0.3. Up to 0.4, 0.5 is considered normal. That means the cup is about half the size of the disc. But then the disc remains the same, but the cup keeps on expanding till you can't see the disc at all. The whole thing is the cup, which is white. So cup disc ratio of 1, which means that is called glaucomatous optic atrophy. The nerve is completely atrophic. You can see the picture on the top, an enlarged white cup, and the margins are so thin of the disc. So this is how, so we can take pictures. Previously, we could only do an ophthalmoscopy, but now we can take pictures and actually use an instrument called a fundus camera to record it for posterity and to show the patients. So I said about optic pressure, the nerve, the pressure in the eye is what we measure. Second thing we measure is the nerve. We look at it, we take pictures, we can take photographs. And the third thing is we want to see how much damage is actually there. We do a test called perimetry or visual field analysis to see the visual defects. So if you see that machine, you sit there inside with your chin on the chin rest, and there is a hemisphere inside in which spots of light are shone from different sides, and you're given a trigger in your hand. You press the trigger every time you see the spot of light. So we want to see whether you can see that spot of light when it goes in the periphery. The whole test takes about just 15 minutes. So the top picture is a normal visual field where everything is nice and white. And you see that one small black patch in the center, that's where the optic nerve enters. That is called the blind spot, which is normal. But then as time goes by, you get more and more of the blackness that is coming till you get a tubular field. So this is the worsening of the visual field defect, and we can store it in the computer and compare every 3 months if we want to. So this is how it looks. Here the upper half is completely lost, as you can see, black there. Lower half is preserved, and so on. There are even more sophisticated tests. So the basic tests I told you about, the measurement of the eye pressure, the looking at the optic nerve, and the third I told you was the visual field analysis. Then there are more sophisticated tests, little more expensive, which we will do when we are confused about the diagnosis. So we have, just like a CT scan, we have optical coherence tomography. We take pictures of the retina and of the optic nerve to see exactly the thickness. We can measure it, all computerized. Heidelberg retinal tomography, scanning. These are some sophisticated tests. I won't give you too many details of this, but this is how how it looks. The picture that we get, the printout that we get, and if all those circles are green, then everything is normal. If there is, you see those 4 circles that I showed you. So in different segments, if all is green, it is fine. If it is yellow or red, that means in that area the nerve is thin. And this is the nerve fiber layer. On the left of the diagram, there is a black line going through the green portion. So if it's all in the green portion, then it's fine. If it dips into the red, that means the nerve fiber layer is thinning down. Let's move on to more clinical things. Now that we've diagnosed when can glaucoma affect us? Usually it's in adults after the age of 40, but sometimes you get what is called congenital glaucoma. Child is born with glaucoma. It is then called buphtalmos. Buphtalmos means bullseye. If you can see the first picture, unilateral buphtalmos, the right eye is normal, the left eye is enlarged. The cornea is steamy, it's not transparent because water has gone in, because the pressure in the intrauterine life only was raised. And in this poor child on the other one is bilateral buphtalmos. Both eyes are affected. See how steamy the corneas are. This child will require urgent surgery to bring the pressure down, and that corneal steaminess can reverse and you can get a crystal clear cornea. So if we operate early, I've sometimes had to operate an 8-day-old child or a 15-day-old child under general anesthesia. In adults, basically there are 2 types of glaucoma. One is called a narrow angle glaucoma. Narrow angle means the pathway for the fluid to go down is reduced. It is like having a basin, and the trap in the basin is choked. So the fluid cannot go out. So how do we diagnose whether the patient has a narrow angle, closed angle, or an open angle? We do it by an instrument called a gonioscopy lens. So gonioscopy lens has got some prisms in it. We hold it on the slit lamp and we can take pictures of the angle of the eye. I won't bore you with what it all means, but there are a lot of structures we see at the angle, and by looking at the angle, we can make out. It requires a little skill, gonioscopy. Nowadays, we have modern instruments so that it's idiot proof. You can send the patient for what is called a UBM or an ultrasound biomicroscopy. So using ultrasound, just like you use for diagnosing pregnancy, we can take beautiful pictures of the angle of the eye and find out whether the angle is open. As you can see, the UBM normal. see the angle between the cornea and the iris. That is quite normal where the arrow is showing. While if it's narrow, you see how the iris is so close to the cornea that the fluid passage becomes reduced. So narrow angle, you can actually measure the angle in degrees on UBM. So on open angle glaucoma on one side, narrow or closed angle glaucoma on the other side. Why is it important to know this? Because the treatment differs. There are various eye drops. Glaucoma is first treated with eye drops. So eye drops either decrease the production of aqueous humor. As I said, if the tap is too high, open, you reduce the amount of fluid coming. So there are drops to decrease the production of aqueous or to increase the outflow of the aqueous humor. So to open the angle, to allow more fluid to go out of the eye. We have drops which can do both. But it is important that we teach the patient compliance. They must put the drops. Many patients get bored. After a month and 2 months, they stop. And the pressure rises again and they don't come to us for a year. So in glaucoma, if they are prescribed eye drops, the daily usage, if the doctor has said once a day, twice a day, thrice a day, they must continue. So the first drops which came in almost more than 100 years ago was a drop called pilocarpine, which constricted the pupil and moved the iris away from the angle, so increasing the outflow. So it is very useful in narrow angle or closed angle glaucomas. Now we have lots of other anti-glaucoma drops. Again, I won't go into details of all the medicines, but we have drugs to reduce aqueous production like dorzolamide or brinzolamide, drugs to improve the outflow, which are called prostaglandin analogs or brimonidine. Then there are beta blockers like timolol, some newer discoveries like ripasudil, netrasudil. So we have lots of new drugs in our armamentarium, and most of the time we can treat glaucoma. Treat meaning we can prevent it from becoming worse with just medicine alone. If medicine doesn't act, or if it's very severe or end stage of glaucoma, and if the angle is narrow, then we can do a peripheral iridectomy. That means we make a small hole in the iris so that the fluid can flow out better because the iris will not crowd the angle. This can be done by surgery or by laser. This is only for narrow angle glaucomas. But for any glaucoma where the eye drops are not working, the commonest anti-glaucoma operation, which is more than 50 years old, is called trabeculectomy. We open a flap in the sclera, the white of the eye, and make a new pathway for the fluid to flow out and then close that flap again. Trabeculectomy works in almost 90% of cases. If that is not possible for some reason or trabeculectomy has failed, then we can put in a stent or a glaucoma valve. So a valve is put inside the anterior chamber so that the fluid continuously flows out from that. So glaucoma valve surgery is the final surgery that you can do. And if trabeculectomy fails, it's not a surgery of first choice because it's a complex surgery, a difficult surgery to do. But if trabeculectomy fails, then a glaucoma valve is done. Thank you so much for your attention. I hope I've given you some food for thought, and I hope I've made it interesting enough for most of you. Thank you so much. I'll stop my screen share, and I'll be most happy to answer questions.
Thank you so much, sir, for giving your precious time and sharing your knowledge with us and making this session informative one. I can see we have received some question from the participant, and if you allow, can I take this question with
Please
all
go
your
ahead.
permission?
Yes.
Yeah, I can see the first question is, how is intraocular pressure IOP measured in the evolution of a glaucoma suspect?
So as I mentioned, I think that person must have joined in a little late. There are several instruments by which we can measure, but once we have diagnosed it as glaucoma, we usually follow them up on an instrument called Goldman applanation tonometry on the slit lamp microscope in the eye clinic of an eye doctor. Thank you.
Okay, thank you so much for answering it really well, sir. I hope that the participant who have asked this question has received his answer. Moving forward, I can see there is more question. Which age group have the highest prevalence of glaucoma?
The older the patient gets, the more the chances of developing 3 diseases or 4 diseases in the eye. One is dryness of the eye, second is cataract, third is glaucoma, and the fourth is age-related macular degeneration. That's why after 40, we say that everyone should have an eye checkup with an eye doctor at least once a year. Thank you.
Thank you so much for answering it, sir. I can see a couple of questions are there. We will be taking last 2 questions for today's session. The question is, what is the prognosis for glaucoma?
if the glaucoma is detected in an early or moderate stage, we can almost 100% assure that we will prevent it from progressing further. First, we try medicines because glaucoma is a very slow progressive disease. So we have months in which to try different medicines to see whether we can achieve a good target pressure. If we cannot achieve the target pressure with even with the modern drops, then we will advise trabeculectomy surgery or valve surgery, but we will definitely be able to halt the progress. We cannot reverse the damage already done. That's why a stitch in time saves 9. The earlier the patient comes in, when there is no visual field damage, that is the best time. Then we can give him a good, healthy vision for 100 years of age. Thank you.
Thank you so much for explaining it, sir. I can see there is one last question, and this is a very good question. And the question is, how is the optic nerve head evaluated in the glaucoma suspect?
The optic nerve, as I said, that we have a direct vision of the optic nerve head using ophthalmoscope, direct or indirect. We can also take serial pictures, fundus photographs of the optic nerve, and the computer then, suppose I take a picture today and I take a picture after a month or 2 months, my computer has a program in which I just simply put the images in the computer, and the computer tells me whether the nerve is getting damaged or not, because it takes all the measurements of the optic nerve head, the disc, the cup ratio, all that is measured. So I don't have to depend on clinical impression alone. I have got computers to help me as well. Thank you.
Sir, very glad to know you have answered all the questions, sir, and thank you so much for taking out your precious time, sir. As I can see, there is no more question from the participant end. If you allow, sir, can I conclude this session with all your
Yes,
permission?
please. Thank you.
Okay, thank you so much once again, sir. Until then, take care of yourself and hope to see you again with different topic on the IGCP MedTalks platform, sir. Bye,
Thank
sir.
you.
Thank
Thank
you.
you.